Research is the cornerstone of innovation in clinical practice, driving improvements in patient outcomes and shaping the future of medicine. Welcome to the Global Rhinology Network Topical Research Symposium. I am Ashok Rokade from Winchester, UK, and it is my privilege to welcome you as a host. Joining me as co-hosts are Louise Melia from Bath, UK, and Professor Thibault Van Zele from Ghent, Belgium. This symposium showcases fascinating topics across 4 key modules: General Rhinology, COVID session, and Research in Chronic Rhinosinusitis. A special highlight is the PhD session featuring research conducted by enthusiastic young rhinologists who represent the future of our field. This symposium brings together leading global minds in rhinology who will highlight latest developments with a focus on translating research into impactful patient care. The Global Rhinology Network is dedicated to advancing knowledge innovation. Thank you for being part of this exciting journey. Thanks to Medtronic and Karl Storz for their generous support in making this symposium possible. Welcome to GRN-Topical Research Symposium.
The last speaker that we have in our COVID session is Dr. Sophie Hoffman. Dr. Hoffman's a specialist in otolaryngology and allergy and works as a senior physician at the University Medical Center in Hamburg, Eppendorf, and earned her doctoral title in Kiel with her thesis looking at P16 overexpression predicting translational active HPV infection in tonsillar cancer. And today we're going to hear her talk on reduced olfactory bulb volume accompanies smelling dysfunction in COVID-19. Thank you.
Thank you for the introduction. Can you please share the screen from your? Yeah, perfect. Thanks. Oh, I hope everybody can see it now. Thank you. Perfect. Thank you for the invitation, especially to Thibault for asking me. And I will talk today. I will not make it in like 2 minutes, but I try to tell you a little bit of our research we are doing in Hamburg. It's hopefully a little better than the German soccer team. So give me like 10 to 15 minutes to explain it to you. So it's the topic is the reduced olfactory bulb volume and if it accompanies to smelling dysfunction in COVID-19. So we have heard of this very often. So the predominant symptom of acute COVID-19 is often olfactory dysfunction, and it's often a commonly persistent symptom. The prevalence, we don't exactly, we know it, but it varies from type to type. So depending on population, the variant, the severity, the age of the patient, and the method of the assessment. So we know that the determinants of olfactory dysfunction is still incomplete, and there is lots of research going on in this topic. And we know that the virus might affect the olfactory system at different breakpoints, from disruption of sustaincular cells and olfactory sensory neurons situated in the olfactory mucosa, to functional disarray of the olfactory cortex. And it's the only vague understanding of how these aspects relate to clinical outcomes. So then you have the MRI, which provides a promising avenue to investigate the pathomechanisms of substrates of the olfactory dysfunction in SARS-CoV-2 infections. And the volume reduction of those of the olfactory bulk accompanies the olfactory loss in conditions like acute rhinosinusitis or chronic rhinosinusitis or head and neck trauma. The abnormalities in psychological olfactory testing are demonstrably associated with the volume alterations in health and disease, and the duration and the degree of olfactory loss is proportional to the OB volume. So the studies, they are relating OB, like the olfactory bulb volumetry and the olfactory function in COVID-19. And that we have seen only small sample size with heterogeneous results. And that's the reason why further investigations were warranted. And we in our group thought of how can we get a bigger group of patients to find a little bit more out about the volume. And in Hamburg at the moment, we have the luck to be part of the Hamburg City Health Study. It's a huge cohort study. And the aims of the studies are to find prognostic factors in chronic diseases. And it includes, at the moment, almost 20,000 patients, supposed to be 45,000 in the near future. And the participants are between 45 and 74 years of age. They are all inhabitants in Hamburg. And we had included several ones in the first wave who had been affected with COVID-19. And therefore, in 233 patients, we had MRIs, and we thought we have a look at the olfactory bulb and elucidate the correspondence between the bulb and the clinical outcome of COVID-19 related olfactory dysfunction. So here you can see the methods. We started on the top. You can see the Hamburg City Health Study where we included them, or we used the data from, and we analyzed 233. We analyzed the data of the 233 COVID-19 convalescents. They were all PCR positive. And as I already said, they were between 45 and 74 years. They all had a cranial MRI, and they had an assessment of the olfactory function after the recruitment and follow-up via questionnaire. The problem was that we just had all the patients who have been included in the study just had the question, did you have olfactory dysfunction before, during, and after? So we just had yes or no answers, and we didn't have any sniff and stick testing or any screening test included in the study. And then we thought, okay, well, we can use the olfactory bulb volumetry, and we used a novel, fully automated deep learning-based pipeline designed for OB volumetry. And we called all those patients in again and did sniff and stick screening testing with the ones who were willing to come again to the hospital and do the testing with us. Here you have the timeline again. So we have the PCR positives, the acute infection, and it was between it was in the first wave. So in between the 1st of March 2020 and the 31st of December 2020. Then we have T1 and T2. I will just tell you because later I show you in the results the different timeline spots. And here you see the baseline examination with the MRI, and the questionnaire was given to the patients, or was practiced with the patients around 8 months later. So it's quite a time difference in the average, but we didn't have any other possibilities of having an MRI in this case as earlier. And then we invited them this year in March and April to come to our ENT department again, and we just did a screening test with the sniff and sticks and let them fill out another questionnaire. So the average was about 21 months later. Here you can see an exemplary visualization of the olfactory bulb, and the first subject was a patient who had no olfactory dysfunction, and the olfactory bulb volume was about 67 millimeter not square. I can't think of the three right now. How it's called? Sorry. You see the overview of the segmentation of the olfactory bulb, and you can see it from the left to the right: coronal, axial, and sagittal. And the red is the right olfactory bulb, and the left is the blue is the left olfactory bulb. Here, one more, the coronal slices in a light box, and again on the left side without segmentation, and on the right side with segmentation. And in comparison to that, here you can see it with a male patient who was 58 years old, and he had subjective olfactory dysfunction. As well, on those slots here on the left side without, and on the right side with segmentation. And here you can see that our longitudinal assessment demonstrates a declining prevalence of olfactory dysfunction from 67% at the acute infection and 21% at baseline, so at T1 8 months later, and then 17.5% at follow-up. So at the time we saw them again at our hospital. And here on the bottom you can see, like, here's the 67%, and then you see it's going less and less. And this is kind of what the literature also says. So it's similar to the results has been shown before. And here on those plots, you can, it's always compared to olfactory score, so T2. And here you see there's not really a difference between the patients, the ones who have been normal and the ones who have been impaired at the time of acute infection. But you see a significant difference at T1 and T2 between the impaired and the normal ones. And then here we can say that the participants with post-acute olfactory dysfunction, they had a significantly lower olfactory bulb volume at scan time than the normal smelling ones. And the olfactory bulb volume successfully predicted the olfactometric scores at follow-up. Here's one more, like a little demonstration on the olfactory bulb and our automated deep learning pipeline. Here you can see it from all different sizes. And yeah, I think it's quite impressive how it shows those olfactory bulbs. The question has risen before if we have seen in some patients no olfactory bulb. Yes, we have seen in 3 patients there was no olfactory bulb to be measured. So, and then it comes to the bulb volume. Here you can see at acute infection there is not really a difference, but then you can see a significantly difference between T1 in T1 and in T2 between the two groups, the normal ones and the impaired ones. As well, which is interesting, I think, so the ones who are still impaired, they have a lower, a smaller bulb volume than the ones who are convalescent by the time now. So of course, all the rhinologists or the ones who are like more into this topic ask, why did you just use the screening test? Because we feared compliance problems with more time-consuming tests, like odor thresholds or like bigger testing for olfactory dysfunction. And we were thinking of a very high risk of dropout rates because they all had to be called again and they all had to come in and do the testing again at the hospital. So this is definitely a small screening test, but I think it gives you a good idea. And of course, the limitations of the study are that the MRI is not, it's just at one time point and not like at the time of acute infection and then let's say 10 months, 15 months later. And of course, again, the test type of the olfactory testing. So to conclude, The olfactory bulb volume was demonstrably lower in individuals with sustained olfactory dysfunction. The results highlight the olfactory bulb volume as a surrogate marker that may inform the diagnosis and guide the rehabilitation strategies in COVID-19. And it shows us again the relevance of the olfactory system in the overall pathophysiology of the disease. Thank you very much. This is just a picture of our cooperation partners, the ENT department, the neurology department, with a few tech specialists who are very firm in deep learning, and the epidemiological study center from the HCHS. Thank you very much, and I'm open for questions.
Thank you, Anna. That was wonderful. We explored further about olfaction, impact of COVID on olfaction. So any questions from the panel, from the audience?
Can I just ask you, Anna, do you think going forward, all patients coming with anosmia, you would like to see MRI imaging done for them, and specifically asking the radiologist to look at the olfactory bulb volume?
We probably have to find this. I think it's very difficult, because in our clinic, of course, the ones who come with anosmia and you don't really know the reasons. I often do an MRI, but I don't think that like, you really have to think if you need an MRI and what you will find out in the MRI. But yes, I think it's an important tool, and we should use it more often. But it definitely needs more research in this topic. And I know that our data is in some point probably weak, because of the long time in between the acute infection and then the MRI, but you can see still a significant difference. So I think it definitely has to be something with the volume, which we have to find out more about it.
Thank you.
Thank you, Anna. Can I ask you a clinical question? So in your current practice, if the patient approaches with anosmia with a history of recent COVID, what is your management?
Just depending on how long it has been. Like when it's like 2 years ago and they ask us what can we do, I still let them train. So I give them like I tell them by the smell things. I don't know how they're called right now in English, but anyway, I just tell them to train their smell, and we actually do give them colder stops, so with vitamin A drops, and also sometimes we tried with omega-3. So in patients we see which have just had COVID and are still struggling with olfactory dysfunction. Sometimes we do an MRI just to be sure that it is not only because of the infection and that there is any other pathologic finding. And this is actually how we proceed in our outpatient center at the moment.